Not all the structures in the cranial cavity are pain sensitive. The pain sensitive structures include cranial venous sinuses with afferent veins, arteries at the base of the brain and their major branches, arteries of the dura near base of brain and large arteries, dural, cranial and extracranial nerves. These are all pain sensitive, and all the extracranial structures, they are pain sensitive. Now the insensitive structures include brain parenchyma. It doesn't have any pain nerve endings. Ependyma, choroid, pia, arachnoid, and dura over the convexity. Now see, dura over the convexity, it is pain insensitive, while the dura near base of the brain and large arteries is pain sensitive. And then we have skull, which is also pain insensitive. Now, broadly categorizing the headaches according to the International Classification of Headache Disorder, we have a group of primary headaches and we have a group of secondary headaches. What is a primary headache? Basically, a primary headache disorder is not caused by an other underlying disease, trauma, or medical condition. Underlying disease like infection, CNS infection, or some space occupying lesion like brain abscess or brain tumors, or any vascular abnormality like intracerebral hemorrhage, venous sinus thrombosis, or you can say arterial dissection, or any medical condition like hypertension or any other cause, or any trauma. So trauma can lead to contusion, trauma can lead to subdural hematoma, and similarly pain can arise. It accounts for about 90% of all headaches, and secondary headaches are caused by exogenous disorder, as I mentioned earlier, that these can be due to trauma, infection, neoplastic, systemic, vasculitic, and so many things can cause secondary headaches. Even uncontrolled hypertension or accelerated hypertension, hypertensive encephalopathy, these can all cause secondary headache, even meningitis, sinus infections. Okay, now the primary headaches. The three main type of primary headaches are migraine, tension type headache, trigeminal autonomic cephalalgias, of which cluster headache is the most common one, although it is quite less common as compared to. And then we have other primary headache disorders. Now, as shown in this picture is depicting the site of headache in each of these. You can see the pain in the tension headache, it is like a bend squeezing the head, it is bifrontal, and in migraine it is unilateral, it may involve the face, even can radiate to the neck, and in cluster it is basically periorbital or orbital sort of headaches, and sinus pain is behind her brow bone or the cheekbones, so sinusitis can also cause headache. Okay, so secondary causes of headache, as I've already given you few causes, again the same repetition, vascular causes, raised ICP due to any cause can cause secondary headache, and space occupying lesion of any sort, whether infective, whether neoplastic, vasculitis, hypertensive and gap, all the causes. Now coming to the need of neuroimaging, all the patients with headache, they do not need neuroimaging, and if you find certain things suggestive in the history or examination, then you should decide about getting a CT or MRI done. Every patient with headache doesn't need a CT scan. CT scan, it imposes risk of radiation to the patient, and one CT is equal to 200 X-rays, so it's better to avoid imaging if not needed. If you find focal neurological findings like weakness of any body part, either hemiparesis or monoparesis, or if there is some cranial nerve palsy, or headache is starting after exertion or Valsalva maneuver or during the exercise, then you should get imaging done, because maybe it can be subarachnoid hemorrhage or it can be some AVM which is ruptured, you never know. Acute onset of severe headache, okay, that is also an indication. Headache which awaken the patient from the sleep. Change in well established. Now this is very important. For example, if a patient has been a regular migrainer, he is having migraine headaches off and on, sometimes he has tension headaches also, and suddenly one day he comes in the ER that he has most severe headache of his life, and it is different from his migraine headaches, and it is very severe and he just cannot tolerate it, please take it seriously. Migraine headache patients can have any other problem as well. They are not immune to it. And if there is change in the character and intensity of the headache, you have to take it seriously. You have to take it seriously whether it is an acute onset one or whether the intensity of pain has changed, the type of character of the pain has changed over weeks or months. The new onset headache in any patient who is more than 50 years of age, think about temporal arteritis and maybe a neoplastic lesion, most likely secondaries of the brain, metastatic lesions. And new onset headache in a patient who has HIV or he is diagnosed with cancer or who is immunosuppressed because of any cause, whether he's on some immunosuppressive drugs, or any patient who has a history of malignancy. Coming to the prevalence or epidemiology of headache, lifetime prevalence, most common tension type. Second is migraine, then comes cold stimulus, and then comes the cluster headache. The general mechanism of headache. What basically causes headache? As I've already mentioned, the pain-sensitive structure of the cranial cavity. Whether there is traction on the major intracranial vessels, it can lead to headache. Whether there is distension, dilation of intracranial arteries, which is most commonly implicated with the pathogenesis of migraine, that can lead to headache. And whether there is inflammation near the pain-sensitive structure, like they can be referred from the surrounding structures. Whereas there is direct pressure on the cranial or cervical nerves, and there is sustained contraction of the scalp or neck muscle, which is usually part of tension type headache. And sometimes even migraine patients, they can have pain radiating to the neck. And then stimulation from diseases of eye, like glaucoma, it can give rise to headache. And even the ear issues like otitis media can give rise to headache. The nasal problems and sinusitis, they also can cause headache. That is sort of a referred pain. When you approach a headache patient, the first thing that you have to start with is history. Now, history is the foundation of your diagnosis, always in any patient. So this is a general sort of history questions which are can be applicable in the patient who are coming to the ER, who are coming to the OPD. See, we have different sort of patients. Some patients have those who are coming with ER with acute headaches. Okay, so our approach will be different in that patient, and the patient who are coming in the OPD with chronic headaches, which are either daily headaches or either these are episodic headache, and then there we are differential and approach will be different. But you should know all these important history questions, like for example, first of all, duration, since how long having headaches, then whether it is constant or it is episodic. And if it is episodic, what is the duration of each episode? Again, it is very important in differentiating different types of headache syndromes. Where does it hurt? Is it in the whole head, bilateral? If it is unilateral, is it in the frontal region? Is it in the occipital or is it in the facial region? Character of the pain is very important again, whether it is a bending, tightening, stretching type of pain, which is a feature of tension type headache, or whether it's a throbbing pain, which is mostly in migraine, whether it is an episodic jabs of pain, which can occur in idiopathic stabbing headache, or whether it is a dull pain, it is a constant pain. So you need to ask about character of pain and what other symptoms do you experience. Nausea, vomiting. If there is any altered level of consciousness or loss of consciousness, that is very important. It points towards some serious pathology. Then flushing and lacrimation, whether there are drop attacks, whether patient has neck stiffness, whether he has photophobia, whether he has fever. These all questions are very, very important. Whether he has some, why did this headache bring you to the emergency? Why? That is important question. Whether it was your first or worst ever headache, or whether it was accompanied by some new or frightening feature like loss of vision, like hemiparesis, or maybe weakness of one leg or one arm. So that's why the patient landed in the emergency department. And then the question, have you had previous similar headaches? If so, when did this headache type start? The history of precipitating and aggravating factors is important, like if it's precipitated by noise or with lights, there is photophobia, phonophobia, whether it is precipitated by foods or some sort of extreme weathers, or whether it is by menstruation is precipitating it. Then whether relieving factor, whether the patient gets relief in the dark room or whether in certain position or with certain medications. Then the medical history is again very, very important. If the patient is hypertensive, has he stopped his antihypertensive medications? Whether there is any history of malignancies in the past, whether there is any history of intake of immunosuppressive drugs currently, whether he has HIV positive or any risk factor for it, and recent procedure, LP done due to any reason. It can lead to post-LP headaches and change in medications. That is also important. Then we come to family history. Okay, so family history can be positive in migraine headaches and also in subarachnoid hemorrhage. There are some familial aneurysmal uh, diseases which run in the families, like polycystic kidney disease. In polycystic kidneys, we have cysts in the kidneys, polycystic kidney, and we have intracranial aneurysm. And polycystic kidney disease is an hereditary disorder. So you may get history of subarachnoid hemorrhage in the family and early sudden deaths due to same. And migraine headaches, they can very well have 50 to 70%. They have family history. Environment, like if there is a cause which is exposing the patient to carbon monoxide poisoning, that is also important. Now this is an example of a headache diary, and it is given to the patient and he fills it out daily, and when he comes for a visit he should bring this diary. This diary helps in evaluating the pattern of the headache and the treatment effect. So this is very important, and I think every headache patient who is coming to OPD should carry this sort of diary with recording of all the headache pattern and the treatment effects. Now, this is list of symptoms which is pointing towards some serious underlying disorder. It means it is pointing out towards a secondary cause of headache. Worst headache ever. It can be subarachnoid hemorrhage, or it can be any vascular pathology like intracerebral hemorrhage. It can be due to cerebral venous sinus thrombosis. It can be due to arterial dissection. First severe headache, again the same differentials. Whether it is subacute or worsening over days or week, maybe some neoplastic lesion, maybe brain abscess, or maybe chronic meningitis. Abnormal neurological examination, again there is some structural problem, whether it is a vascular, whether neoplastic, infective. So fever or unexplained systemic signs like cough or weight loss, and these may point towards some systemic infection like TB, meningitis. And then there is vomiting, which is preceding headache, and it indicates raised intracranial pressure. Pain induced by bending, lifting, and cough, again indicating raised ICP. Pain which disturbs sleep presents immediately upon awakening. That is also due to secondary causes. Known systemic illness like vasculitis, like SLE, or some other diseases, they can produce CNS involvement and cause headache. And if the onset is after 50 or 55 years, you have to think about secondary causes. And pain with local tenderness points toward temporal arteritis, especially the temporal artery tenderness. And then comes the physical examination. Vital signs, very important. If fever, think about infective causes. If hypertension, BP is very much raised, think about hypertensive headache. Now you can look for bruise, you can look for temporal artery tenderness in the scalp. In eyes, you can see the conjunctiva if it is congested. If there are pupillary abnormalities, if there are some cranial nerve palsies when you examine for the extraocular movements. So that is very, very important, because these can point towards something inside the cranial cavity that is causing this cranial nerve palsy, something in the brainstem, or maybe a false localizing sign like a sixth nerve palsy. Papilledema, very important, as it denotes the presence of raised intracranial pressure. Then ears, we can ask for history of ear discharge, and we can ask for any injury, and there can be otitis media or hemotympanum. In mouth, it can originate from infected tooth, infected carious teeth, or tooth, TMJ dysfunction, that is temporomandibular joint dysfunction, and it basically produces pain when the patient opens and closes the jaw, especially during the chewing, and it is usually referred, and patient, they basically complain of headache, but actually the pain is originating from the temporomandibular joint. So that is one cause. Then come to the neck. neck, you can check for stiffness or tenderness, and you can also auscultate for carotid bruits. Carotid bruit is auscultated with the bell of your stethoscope, and you need to ask the patient to hold his breath. Otherwise, you cannot. You can mix the breathing sounds and the sound of the bruit together. So you need to ask him to stop breathing for a while, and you should ask for bruits. Listen for bruits. And skin rash, it may point to some underlying vasculitis like SLE or any other systemic disorder. And neurological examination is again important. If the patient is in altered mental status, take it serious. It can be something definitely serious. Then we have pupil. If there are unequal pupil, it can be sign of herniation. If there are extraocular movement abnormalities, there can be something wrong in the brainstem, or there may be raised ICP causing six nerve palsy. Visual fields are important. It can point towards pituitary adenoma, and sometime when there is hemorrhage in the pituitary adenoma, it can lead to vision loss as well and altered consciousness as well. Look for focal deficits. Look for Horners, and Horners can occur because of carotid artery dissection, either extracranially or intracranially, because the sympathetic chain, these are surrounding the carotid artery. Then ataxia. It is unilateral ataxia. Think about some space occupying lesion of the cerebellum or some hematoma in the cerebellum. So that is your neurological examination. Okay, so now we will discuss these primary headaches one by one. So let's talk about tension type headache. It is 2 to 3 times more common in women. It is the most common primary headache. It is bilateral in 90%. It is usually a dull, band-like and stretching kind of pain, and it is usually long duration pain. It may be episodic, it may be chronic, and it is present for more than 15 days per month most of the time. And 10% patients of tension type headache, they may be suffering from migraine as well in addition to their tension type headache. And up to 50% of the patients, they say that the headache is occurring daily. So just revise it. It is a dull, tight, band-like, stretching type of headache. It can be episodic, it can be chronic, and in 50% the headache is almost daily. Again, the features: tightness, pressure, delay, band-like, bilateral, radiate to the neck and shoulder. These features are very important in differentiating different sorts of headache. It is intensity is mild to moderate, and it is not aggravated by movement or is not associated with nausea, vomiting, or sensitivity to light or noise like photo and phonophobia like it occurs in migraine. These are not the features of tension type headache. And the duration is 30 minutes to several days. As I've told you, this usually present 15 days of a month. Now, when we come to the management, the acute treatment is involving simple analgesic like acetaminophen, as even we can use aspirin and we can use NSAIDs also, but not very frequently. Behavioral approaches including relaxation can also be effective, and there is high risk of rebound headaches when you withdraw the painkillers like analgesics. So it is said that you should limit the acute treatment to 2 to 3 days per week, because if you start giving them NSAIDs or acetaminophen on daily basis, the patient will develop medication overuse headache, and when you stop it, they will have rebound headaches. Now, the preventive treatment, it is given in chronic tension type headache. When the headache is remaining for more than 15 headaches per month, we call it chronic, and it can even be episodic. It can be chronic. When it is chronic, again, we have non-pharmacologic approaches like proper sleep hygiene, stress management, biofeedback, and physiotherapy sometimes help. And in pharmacologic, we can offer them tricyclic antidepressant like amitriptyline. Now come to migraine. Approximately 5% of men and 10 to 15% of women are suffering from migraine. First attack usually occur in adolescence or in young age, and remission is common after menopause or in 5th and 6th decades. 50 to 70% report a family history. This is important. Pathophysiology, there are different theories, and the vascular theory is the most accepted one, in which there is dilatation of the vessels inside the brain. The characteristic of migraine headaches, it is unilateral, but it can be bilateral. Pain is throbbing. It may not even be throbbing, but it is moderate to severe in intensity, and it does affect the activities of daily living. It does affect your work or school, or it causes absence from school sometimes, from office, and it is aggravated by movement or activity. Duration is 4 to 72 hours, and it can be associated with either nausea or vomiting. And if there is photophobia, then photophobia and phonophobia both are usually there. Okay, so let's come back to the migraine headache character. Unilateral but can be bilateral, throbbing pain, moderate to severe in intensity, aggravated by movement, disturb the activities of daily living. This is very important. Nausea or vomiting, photophobia or and phonophobia, and 4 to 72 hours duration. Now these are different migraine symptoms and stages. These slide you can see there are 4 stages. Okay, so stage 1 is usually a prodrome, when the patient is going to have a migraine. Before that, he starts having symptoms of photo and phonophobia and irritability and maybe lack of appetite. The second stage is not occurring in each and every patient, because the second stage is aura. Migraine with aura is only 20%, and most of the migraines, like 80% of the migraines, are without aura, which is also known as common migraine. So if the migraine is associated with aura, the second stage is aura. It occurs up to 5 minutes to 60 minutes before the headache, and they experience different visual symptoms like flashing lights or geometric patterns which obscure the vision, and sometimes the entire half of the visual range is affected. Then comes the stage of headache, which I've already described the type and character of the headache. And then the stage 4, it is postdrome. And postdrome is that these are symptoms which can last even days after the migraine attack has subsided, and it is usually known as the migraine hangover. And most migraineurs, they suffer from it, and they feel irritable and fatigued. They may have difficulty in concentrating, and they may have mood changes, and there may be scalp tenderness that is called allodynia. For example, when they comb their hair, they feel that their scalp is tender. So that is also part of migraine. Now come to the precipitating factor. This is very important, because once you know the precipitating factors, we can avoid them with lifestyle modifications. Increased incidence on weekend and holidays. Why? Because the sleep pattern has changed. Mostly people, they keep awake till late night on weekends and holidays, and they get up late in the morning or afternoon, and the sleep pattern has changed. So it is a precipitating factor. Then menstruation, it can also, in some women, it is related to menstruation. Stress can aggravate it. Fasting or missing a meal, and dehydration. Certain foods like chocolate, cheese, alcohol, these can precipitate it. And extreme changes in weather, like extremely hot weather or extremely cold weather, and sleep disturbance or lack of sleep can also be a precipitating factor. Now this is migraine without aura, which is known as common migraine or hemicrania simplex, we can call it, but usually known as common migraine. And if there is migraine with aura, there are 4 types of aura which are identified: visual, sensory, and language. Most common is the visual aura, which is you can see in this picture. This is example of visual aura of migraine, and in this picture there is initial small paracentral scotoma, and it is in this picture, as you can see, after 5 to 7 minutes it has started enlarging, and here you can see a large scotoma. It is obscuring much of the central vision. It's after 15 minutes, and at 25 minutes it has started breaking up. Okay, this is again example of a migraine with the visual aura, and almost the entire half of the this vision is affected. Here you can see different types. Right? In this, there is a isolated paracentral scintillating scotoma. Now, in this picture, you can see as it advances, it can lead to scintillating edges, and there is fortification pattern you can see, and it is involving the entire unilateral visual field. Now in this you can see wavy lines, which we call as heat shimmers also. This is distortion in part of visual field similar to shimmers above a hot pavement. And then metamorphosia, that is distortion of the form, size, or position of object or environment in part of the visual field. Now there are certain dilemmas in diagnosing migraine, because There is some physicians, they believe that the symptoms are very much typical, and if the patient doesn't have very typical symptom, they don't have migraine, while it is not true. Like visual aura, it is absent in most of the patient, and only in 15 to 20% they experience auras. And patient can even have non-throbbing headache. Up to 40% they have non-throbbing headache, and about same percentage can have bilateral headaches. And sinus pain and these symptoms and weather association, they're often present with migraine, and up to more than 90% of migraine attacks, they have these associations. So this should not be considered as a sinus headache if the patient is having all the other characteristic. Neck pain is often present. About 75% of the migraine attacks, they have neck pain. Now migraine, this is another sort of aura. This is brainstem aura. It is not very common. It is also known as basilar migraine, but just for your information and knowledge, I have added this. And in this aura, patient has brainstem symptoms, and there should be at least 2 symptoms among these, which include dysarthria, vertigo, and tinnitus, and hyperacusis, diplopia, and ataxia, and decreased level of consciousness. Now you have to be very careful when you diagnose a patient with basilar migraine. First of all, it is not very common. Second, if the patient has any risk factor for a stroke or if he is old age, you need to be very careful when you diagnose them as brainstem aura or migraine with brainstem aura. You need to rule out posterior circulation TIA in these patients. Or even when a patient presents first time with these symptoms, you need to rule out other pathologies, any vascular pathologies, any TIAs in posterior circulation before you label them as migraine with brainstem aura. So there should be few attacks with similar symptoms, and then you can, when you have ruled out other possibilities like posterior circulation TIAs, then you can label the patient with brainstem migraine or migraine with brainstem aura. Migraine in women is much more common than men. It's 2 to 3 times more common, and there is probably some hormonal association. And many women, to a certain percentage, like around 10 to 14%, experience migraine associated with their menstrual cycle, and usually during the first 3 days and maybe 1 or 2 days before that. And OCPs, or oral contraceptive pills, they increase the incidence of this factor's risk of migraine in 10 times in women. And half of the women experience improvement during pregnancy, and in menopause also 2/3 the frequency decreases. Now, a few words about childhood migraine. The prevalence is 5%, and it's not very common, and it's less common than adult onset migraine. And the male-female ratio is equal; they're equally affected. Now, the pattern of migraine is very different from adult onset migraine, and they usually have cyclical vomiting, abdominal pain, or vertigo, and headache can be there, but commonly they present with these symptoms, and they are often labeled as abdominal migraine, these symptoms. Now, the children, they often respond to conservative management, and they have shorter duration of attack, and short sleep is also very effective. Sometimes they need prophylaxis. Status migrainous. What is status migrainosus? Both of the following characteristics are needed: unremitting for more than 72 hours, and pain or associated symptoms are debilitating, like nausea, vomiting, photo and phonophobia. And unremitting pain, and it is not better accounted for, means you have ruled out other possibilities, and then you can label as status migrainosus. The management, first of all, comes non-pharmacological management. Number 1 is identification and avoidance of specific headache triggers. As I have already described all the headache triggers, lifestyle modifications are needed. Patients should take a healthy diet. They should regularly exercise, and they should try to stick to regular sleep patterns, avoidance of excessive caffeine, alcohol, and cheese, and avoidance of acute changes in stress levels. Then we come to acute therapies to abort the migraine attack. We have triptans, we have NSAIDs, we have dihydroergotamine nasal sprays, and also injections, but these are not used very frequently because they have bad side effect profile. Mostly we use triptans and NSAIDs and antiemetics like metoclopramide and other antiemetics. The triptans, they are selective 5-HT1B agonist, and there are many triptans. As you can see, at least 6-7 names are written here. But in Pakistan, we have only sumatriptan and zolmitriptan available. Sumatriptan is available in oral form, and zolmitriptan is available in oral as well as in nasal spray form. And then we have antiemetics including metoclopramide. And the antiemetics, basically they prevent and treat nausea, they improve the GI mortality, and they add in the absorption of other anti-migraine medications. Besides metoclopramide, we can use promethazine with the known name of Finargan, and it is again a dopamine and histamine receptor blocker. And then we have prochlorperazine, which is available in per oral and IM and IV. Now it is not available IM IV, only per oral is available in tablet form, and that can also be used. Now coming to migraine prophylaxis. Prophylaxis is not needed for each and every patient of migraine, number one. And number two is that taking prophylaxis doesn't mean that it will eradicate or cure migraine. No treatment can cure migraine. Okay, so the benefit of prophylaxis is that when you combine it with lifestyle modification and you take migraine prophylaxis with your frequent headaches, it will lead to decrease in the intensity and frequency of headaches for up to 50%. So that is a good thing for patients who have debilitating headaches. Now there are a few points mentioned when the circumstances where you need prophylaxis. Like if a patient is having more than 2 attacks per week, that is around 8 per month, that is a lot. If they have maybe 2 or 3 attacks, but the duration is prolonged, maybe more than 24 or 48 hours. If there is severe and disruptive, the patient, they cannot function, like they miss the office, they miss the university, college, school. Regular periodic attacks like menstrual migraine, and patient's preference, or in some special circumstances like they are having exams close and they don't want headaches to disturb them or their ongoing classes. Presence of uncommon migraine condition like basilar migraine or migraine with prolonged aura. And there is one term known as migrainous infarction. Migraine, as I have told you, vascular theory is prevailing in the pathophysiology of migraine. Migraine can even cause infarction or stroke. Migraine prophylaxis, the rule is to start low and go slow. You have to titrate it gradually to uh, achieve an effective and tolerable dose without any significant side effects. And the minimum duration is around 4 to 6 months, but some patients do need uh, more duration of prophylaxis, and you need to reassure the patient that this is not a cure, and this will decrease the frequency and intensity of headache. Now there is little mistake, please correct it. We have 3 type of drugs. Level A drugs are the best drugs available, and propranolol is by mistake I've written in level B, whether it is a level A drug. So we have 3 drugs in the level A: topiramate, sodium valproate, both are anti-epileptics, and propranolol, which is a beta blocker. So in a female patients, probably I'll prefer propranolol, and if she is not asthmatic, and if there are contraindications, then topiramate can be tried. But these anti-epileptics both are contraindicated in childbearing age, so you have to be very careful when prescribing in a married female. And level B drugs, we have amitriptyline, nortriptyline, atenolol, and some vitamin like riboflavin. And level C is candesartan, and less commonly used with unpredictable response or gabapentin. We have some evidence-based non-prescription approaches also, like over-the-counter supplements, including magnesium. And then we have riboflavin, then we have coenzyme Q10, melatonin, and they're with the variable response. Then we have migraine in women, and sometimes we need certain different drugs for these. Like in menstrual migraine, it responds well to naproxen, and there is a triptan, which is unfortunately not available in Pakistan, which is very effective in menstrual migraine, that is rovatriptan. Estrogen patches can be used in pregnancy. You have to be very, very careful because mostly migraines, they get less frequent during pregnancy. But if the patient has headache, you need to stick to the non-pharmacological measures, lifestyle modification, because NSAIDs, they are class category C drugs, pregnancy category C drugs, so you have to avoid them, and you can use paracetamol. If prophylaxis is at all needed, try to use very small doses of propranolol, and if propranolol is contraindicated due to any cause, you can use amitriptyline and triptans. Ideally should not be used. These are category C drugs, but if inevitable, then may be used with the risk-benefit weight. Chronic migraine is a headache fulfilling the diagnostic criteria for migraine without aura, and it is present for at least 15 days per month for 3 months. To label it as chronic migraine, and 8 of which have migrainous features. In absence of medication overuse, there should not be history of medication overuse. Otherwise, I would label it medication overuse headache. In these patients, they also need prophylaxis. Then we have other primary headache disorder. These are not very common. Like some patients, they may have headache associated with cough, which is called primary cough headache. Then there is primary exercise headache, and then there is excess headache associated with sexual activity. And then we have primary thunderclap headache. Now, let it clarify a bit. What is a thunderclap headache? Thunderclap headache is actually sudden severe headache which reaches maximum intensity within 1 minute. That is the definition of thunderclap headache. Now, we have two types of thunderclap headache. One is the primary, in which there is no structural or pathology like cerebral venous thrombosis or any vascular like hemorrhage or subarachnoid hemorrhage. This primary thunderclap headache is due to spasm of the intracranial vessels, and sometimes it is seen in postpartum state. Sometimes it is also called as postpartum angiopathy of CNS. There are different names for this, even called Fleming syndrome, it is called. Then we have cold stimulus headache or ice cream headache. So one should avoid taking cold things like ice cream or cold drinks. Then we have external pressure headache. Like some people have headache when they tie their scarves tightly. Some patients, they may have complained that when they tie a high ponytail, they start having headache. That is external pressure headache. Then we have primary stabbing headache, idiopathic stabbing headache. It is kind of very severe jabs of headache involving the first division of the trigeminal nerve, and these are very short duration, and mostly the patient need only reassurance. But if it is very disturbing, then we can try indomethacin. These are usually responsive to indomethacin. Then there is the Mueller headache. The Mueller headache, there's a headache in a coin-like area of the head. It is limited to that one coin-like area of the head, and it responds to treatment like pregabalin and gabapentin. And there is hypnic headache, which is usually in the older adults, and it wakes them up from the sleep, and it is also again responsive to indomethacin. And then the last one is neurally persistent headache. So this was all about primary headache syndromes and how do you approach a patient with headache. I hope you have learned few things, and if you have any queries